Welcome to Sleep, Sex, and Senility, where we explore the fascinating connections between sleep, oral health, cardiovascular health, hormones, brain health, and longevity. I'm Dr. Kathleen Carson, an oral systemic focused dentist.
And I'm Dr. Ellie Campbell, an integrative physician focused on prevention and healthy aging. Together, we bridge the worlds of dentistry and medicine to uncover how the health of your mouth may influence the health of your entire body.
If you enjoy these conversations, please like and subscribe to the podcast so that you never miss an episode. And if you'd like to stay up to date on new episodes, emerging research, and practical health insights, visit our website and sign up for our monthly newsletter using the link on our homepage.
Now, let's dive into today's conversation.
Before we begin, a quick note. This podcast is for educational purposes only and does not provide medical advice. Please consult your own healthcare provider for recommendations specific to you.
Welcome, everybody, to our next episode of Sleep, Sex, and Senility. I'm Dr. Ellie Campbell, your favorite family physician, double board certified in integrative holistic medicine. And I'm here with my girlfriend and podcast partner, Dr. Kathleen Carson.
Hi, I'm Dr. Kathleen Carson. I am an oral systemic and airway focused dentist, and we are so happy to be joining you here to talk about how the mouth is not separate from the rest of the body.
Absolutely. And there's big news this week. This has been about 14 years in the making, where we have changed the name of a medical diagnosis. So that's a big deal because when I was in school, we called this condition the Stein-Leventhal syndrome, and then it got a new name. It was called polycystic ovarian syndrome. And we knew back then that there was a triad. If women came to see us with 3 symptoms, then we gave them this diagnosis. Those 3 symptoms were acne, irregular or absent menstrual periods, and cysts on their ovaries. If they had those 3 things, we gave them a PCOS diagnosis. It turns out that was really misguided and insufficient to encompass the entire syndrome. And so this year, May 2026, The Lancet, major medical journal, published its findings of the endocrine guidelines that have renamed this. We now call this PMOS instead of PCOS. And it stands for Polyendocrine Metabolic Ovarian Syndrome. And they kept the O in there because they don't want to forget that the ovaries are involved and they're not a cause of the problem, but they're a recipient of the metabolic derangements that can lead to infertility. And many women with PCOS are unable to get pregnant until we fix those underlying metabolic derangements. And often they end up going into fertility clinics where they slam them with drugs or bypass the ovaries altogether and go straight into the uterus with an implantation, when if we had known better about what the root causes were and tried to correct those, we could have helped with the endocrinopathy. Because that first word, polyendocrine, means many hormonal problems. And that's what's unique about this.
Yep. And is it true people with PMOS, now that it's called, some may not even have ovarian cysts?
Exactly right. And that's part of the major reason why they wanted to change this. In my practice, sometimes I would tell people that your PCOS stands for polycystless ovarian syndrome.
Okay. So it's more of a whole body metabolic condition.
Right.
Right.
Polycystic is inaccurate because many patients don't have pathological cysts in their ovaries. They often have, in fact, underdeveloped follicles. They're not getting adequate progesterone. They're not ovulating the way that they're supposed to. So you won't see on ultrasound many cysts. Sometimes you do, but not always. And so we want the name now shifts the focus away from their ovaries to the metabolic and endocrine problems, because we have insulin resistance, metabolic syndrome, high risk of type 2 diabetes, high risk of heart disease, and high risk of liver disease. And I did want to spend a minute or two to talk about liver disease because I want to tell you a story. When I was in college, I was randomly assigned to a roommate, and she turned out to become my best friend during college. Her name was Nancy H., and she was, oh my God, so beautiful. She looked like Karen Carpenter. She was an artist. I was the nerd. I was the science, pre-med major, but she was the art and advertising major. And while I was cramming flashcards, she was designing art and making beautiful things. And she continued to do that after college. She did crafts and sewed and wood crafts, and she was a volunteer, and she was active in her church, and she went to Africa, and everything was marvelous until she had 2 kids. She did not have that much trouble getting pregnant, but after her second child, metabolically, things began to change. She started having irregular periods. She started getting acne. She started getting blood sugar dysregulation, and she started gaining weight, a weight gain that she was unable to control. She always suffered a little bit of depression, and that complicated her willingness and ability to stick with any care plan, right? When you don't feel well, trying to exercise when you're depressed is really hard. And the weight gain continued. And she gained probably, I'm going to say, 80 pounds above her college weight. And so she was diagnosed with prediabetes, and then she was diagnosed with diabetes, and then she was diagnosed with high blood pressure. And then one day she passed a bloody stool, a dark black bloody stool. And she's like, that could be a problem, but I think I'm just going to ignore it and see if it goes away. And her husband's like, let's Google that and make sure. So she went to the emergency room because it's a sign of internal bleeding. Black stool means digested blood. And it turned out that she came out of that hospitalization with a diagnosis of end-stage liver disease, cirrhosis of the liver. And she lived another 3 years and died prematurely at the age of 65 from liver failure because of the metabolic derangements, the insulin resistance, and the liver complications that came as a result of polycystic ovary syndrome.
Wow.
I'm on a mission with her husband to try to educate people about the role of polycystic ovarian syndrome, now called PMOS, because I believe that many women out there have clues in their labs that they have a liver problem that their doctors may not be in tune to, may not recognize, and may not put the pieces together very well. I am hopeful that with the new name of Polyendocrine Metabolic Ovarian Syndrome, that our healthcare professionals will broaden their view of this syndrome and not focus on the ovaries as the problem. The ovaries took the hit because of all these insulin resistance and metabolic syndrome disorders and derangements. So I hope that Nancy's legacy will help 1, 10, 100, 10,000 women with this syndrome talk to their doctors about early detection of liver disease, because the more aggressive we are in treating the blood sugar problems that come along with this, the more we can lower the insulin level. Insulin's a growth hormone, right? Insulin makes your metabolism slow, makes your cholesterol goes up, and makes you gain weight. So if we can get those insulin levels down by talking to people about things like go for a 10-minute walk after you eat, that will mitigate your blood sugar spike by 50% at least and lower your blood sugar as well as your insulin. Will make it easier for you to maintain your body weight and maybe even lose some with simple strategies. Change the order in which you eat your meal. Get all your fibery things in first. Eat your salad, eat your broccoli, eat all those green things off your plate first. Get those fibers in and eat your carbs last off of your plate. That simple strategy can reduce some of your blood sugar spike. Wearing a continuous glucose monitor in your arm to keep track of your sugar spikes, because insulin almost always follows glucose. We don't yet have a continuous insulin monitor. When that comes, that'll be a game changer. But for now, the best we have is a clue of your blood sugars. A normal hemoglobin A1C is around 5 to 5.2. If you start to climb up and your hemoglobin A1C gets to about 5.7, now you're pre-diabetic. Don't let your doctor say, we're just going to watch this, because you're going to watch it right into diabetes. that's when we want to start taking interventions. If your A1C is starting to climb up ever so slightly, we need to sit down and have a heart-to-heart, knee-to-knee conversation with our provider and say, I don't like this trend. I have a metabolic disruption. What can we do to change my trajectory? Because I do not want to get diabetes, liver disease, atherosclerosis, heart disease, heart attack, stroke, cancer, Alzheimer's, all the downstream side effects from this underlying metabolic derangement. So um, I'm grateful that I had time with Nancy when she was on this planet. She was a beautiful, wonderful soul. And I'm very sad that we lost her early, but I also have permission and, in fact, encouragement from her husband to share her story so that other women with PMOS have an opportunity to identify their liver disease early, as well as other metabolic problems that might come from it.
Yeah. So, from the dental perspective, PMOS, as we just talked about, it's not just an ovarian condition. It's sleep, it's inflammation, metabolic, vascular, nervous system conditions. And a lot of times, many of the earliest clues can actually show up in the mouth and the airway first. So I'm here to talk about how dentistry is no longer just about teeth. And the mouth can be one of the earliest windows into systemic inflammatory and metabolic dysfunction. So, one good example, Dr. Campbell was just talking about, insulin and insulin resistance and diabetes. And this is a two-way street with your mouth that most patients have never heard about. Bleeding gums and blood sugar problems feed each other in a vicious cycle. And your mouth can actually be making your insulin resistance worse. And insulin resistance can be making your mouth worse as well. This is something that, if you're dealing with this with your medical group, you really should be looping in your dental team as well, because it can help the dental care, the periodontal care, the paying attention to this can help improve your insulin resistance and help you systemically, but then also vice versa.
Yeah. So, Dr. Carson, how often in your career do you think that you or your hygienist has identified a gum problem that was highly suspicious that the patient had diabetes and didn't know it? How often does that actually
All the
happen?
time. Yeah, all the time. It is one of the earliest signs that can be picked up on. Unfortunately, if you're not in an office that maybe recognizes the oral systemic connections, it might get overlooked as a localized concern. But, when you're with a team that understands the importance of these connections and how the body actually talks to each other, we see it pretty much on a daily basis, to some degree or another. We might see a dry mouth or bleeding gums, periodontal pockets, signs of clenching and grinding. So that's the diabetic connection. But then also, Dr. Campbell was just talking about, cortisol and glucose regulation, and we see the impact on sleep breathing and mouth breathing. And, we see that in the dental office all the time as well. So these signs that we pick up on, just starting to talk to those patients about maybe some other issues that they might be having so that we can get to them sooner and get them the right medical evaluations, like Dr. Campbell was talking about, to raise the awareness. The dental team can provide that early insight if they know what they're looking at.
Right. One of the symptoms that we commonly see from the metabolic derangement of polycystic ovary syndrome, and this is one of those things now called PMOS, that you can
Mhm.
sometimes point out people in the airport. You're like, oh, that girl's got a problem.
Yeah.
And how do I know? Because she's got dark circles under her eyes because she hasn't
Mhm.
been sleeping. She tends to be very large, even obese, and she has acne and a beard, and we can see those
Wow.
dark hairs, that 5 o'clock shadow. And I know that that's a symptom. Acne and hair growth and then hair growth on the face, but hair loss on the scalp. Those are signs of high testosterone in women. So they get this very thin hair on their scalp, 5 o'clock shadow, acne, dark circles, and obesity. And so you can recognize those people. And it's a vicious cycle, right? Once we've
Mhm.
gained this weight from this metabolic syndrome, now, what was previously mild sleep apnea becomes severe sleep apnea, and that worsens my sleep, raises my cortisol, raises my blood sugar, raises my insulin, makes me gain more weight. So it's a
Mhm.
chicken and egg thing, right? So
Right.
now we have a sleep problem and an obesity blood sugar dysregulation problem, but we treat one, we help the other. And when we treat your sleep disorder, we're going to help your metabolic conditions and often make it easier to lose weight. In your
Uh-huh.
clinic, Dr. Carson, do you see patients
Mm.
who get their airways treated and their sleep disordered breathing improves and they lose weight without doing
Oh,
anything else?
absolutely. Like you were just mentioning, one feeds on the other. It's a vicious cycle, and you've got to break that somewhere, because if you have sleep disordered breathing and you're not able to breathe, it dysregulates your hormones. It actually makes it virtually impossible to lose weight. Plus, you're making poorer food choices. And until you are able to sleep, recover, breathe, and rest better, it can be impossible for some of these patients to break that cycle. In fact, one of the physicians I work really closely with runs a weight loss program that he's very successful with when the patients address their sleep and sleep breathing. So it's my role to evaluate if these patients of his would be good candidates for oral appliance therapy or any dental intervention otherwise that's available, so that he can be more successful with the weight loss regimen that he has his clients on, because he knows unless we're working together, we're probably not going to be as successful as we can be. And vice versa as well. If a patient shows up in my office that has a metabolic issue or is overweight or has other things other than just the, sleep breathing, it can be very difficult to open that airway with just an appliance. It's not a magic piece of plastic to get that process started. So a lot of times for me to be successful, especially with the heavier set, more obese, thicker neck patients, I need that physician collaboration. It needs to be a multi-prong attack.
Right.
But absolutely, you got to break that cycle somewhere.
One of the new prongs that we have, although I'm not a big fan of medication if we can avoid it, tirzepatide,
Mhm.
Zepbound, is one of the new weight loss shots that's on the market. But it specifically has an indication for the treatment of sleep apnea.
Yeah.
And
Mhm.
so whether we can get insurance companies to cover it for that is a whole nother story for a whole nother day that may require hours and hours of prior authorization, but it has an indication for the FDA. And the reason is because
Mhm.
it helps to correct some of the underlying metabolic dysregulation of high blood sugar and high insulin that's
Mhm.
driving the weight. And so as the patients lose the weight, their sleep apnea improves. And as they lose the weight, their blood sugar and insulin improve. And so we
Mhm.
can unravel that tangled mess a little bit with the use of prescription drugs. So I would rather not use those if I had other choices first. And
Mhm.
sometimes all we need is some myofunctional therapy. Sometimes, like in my case, I needed a little bit of myofunctional therapy, an oral appliance, and some lip taping. And that was
Mhm.
able to help me lose a few pounds, stop my snoring, and get my
Mhm.
hemoglobin A1C down from 5.7 to 5.2. So, right,
Mhm.
I knew
Mhm.
that that was my clue. I've always had an A1C down around 5.3, 5.4, 5.5, but once it started climbing up to 5.7, I'm like, "Oh gosh, I have a problem. I see this coming. I have an insulin blood sugar dysregulation problem. Let me see what I can do about this." And so we've treated it and things are better. And it's nice to know that we have options, but you have to be attuned to the changes, that subtle changes in your lab work that are easily overlooked. Because if I took my conventional labs to an endocrinologist, I would say, "My hemoglobin A1C is 5.7." He's going to say, "Just keep watching it.
Mhm.
You need to get a little more exercise, cut a few more carbs out of your diet. Let's keep watching it. I'll see you back here in a year." Well, by
Mhm.
then, I could have become diabetic. I don't want to be diabetic. I know what that does to people. So I
Mhm.
intervened early on with my functional medicine tools and found them to be quite successful. So,
Well, and then to your point with the trizepatide and similar type drugs, they can be very helpful to get the weight loss started, and start to break that cycle like we talked about. And when I was talking about the airway and sleep breathing and being able to, be more effective with appliances, one of the biggest places that people lose their weight is in the tongue and the neck and the airway tissues around the head and the neck. And it is a decent percentage for those particular patients that when we can even just take off 10 pounds, that oral appliance can kick in to be way more effective. And then the whole process gets sped up. Then they're sleeping and breathing better, and then the weight comes off more. So they really go hand in hand. But one thing that the medications also won't do, they're treating, at least it's my understanding, the downstream effects of what's happening as a result of the weight gain. But if there's other upstream things such as, microbial imbalance or some other oral systemic infection related type thing, they're not really addressing that.
Not
So what I've seen is some of the patients have come in and said, hey, this medication is solving all my problems. I don't really need your help. That's not really true.
right.
You want to also address those upstream contributors and become healthy overall and not reliant, you know, for a lifetime on drugs and medications. They're a great
Exactly right.
tool to kickstart it for sure.
Yeah, absolutely. And they can also hide some other conditions, right? Because
Mhm.
if you're not going to get your red complex bacteria, for example, assessed, or because you're so pleased that you can now fit in your dress size from 10 years ago that you haven't been able to wear, and your figure looks great and you're sleeping better and your apnea is better, but you have massive mouth inflammation because your red complex bacteria was never addressed, we're going to have downstream consequences from that and increase your long-term risk of atherosclerosis, hardening of the arteries, heart attack, stroke, diabetes, Alzheimer's. So don't let the shots fool you into
Right.
not getting good comprehensive care with deep
Mhm.
dive labs and deep dive exams.
Yeah, exactly. Exactly. And as a dentist, and a dental patient, just a reminder that a lot of times the early signs show up in your gums, in your mouth, in the structure of your mouth. And speak up. We're in a position where we can really make a difference early on for our patients' health and wellness.
Yeah. And I think that when you have this metabolic endocrinopathy, often people are seeking an endocrinologist as their
Mhm.
primary provider for this condition. But I think
Mhm.
because it affects so many body parts, we have to think about an interprofessional relationship, not just the endocrinologist, but somebody who's looking at your cardiovascular and cardiometabolic health. That might be a cardiologist, that might be a well trained primary care provider. We want to make sure that you have a dentist and a hygienist on your team. One of the things with the GLP 1s that we commonly see, we now even have a name for it. We call it Ozempic face, right? We're losing muscle mass because of the weight loss shots. We don't get enough protein and we're losing muscle as well as body fat. And so your myofunctional therapist can be on your team to help you to do those exercises for your face to keep your facial muscles toned and reduce the risk of getting that Ozempic face where you have that drawn, gaunt look that goes along with the nice figure that you've developed, but you can tell you're taking the shots because of your face. So don't forget about a whole metabolic team. You may even include your gynecologist to keep an eye on your ovarian function and your hormones, sex hormones, to make sure that you don't have high testosterone and low progesterone, which can contribute to this problem. Many patients who are anovulatory or don't ovulate well are deficient in vitamin D and magnesium. So you want to work with a functional medicine provider like me who can assess those hormonal, metabolic, mineral, vitamin levels and make sure that everything's functioning optimally so that you give your ovaries the best chance to function well when we take away the insulin and blood sugar dysregulation. Now you may be able to get pregnant where you weren't before, and you can save yourself thousands and thousands of fertility dollars just by treating the underlying root causes.
Mhm.
So I think it's exciting that medicine is catching up with the idea that polycystic ovary syndrome is not just an ovary problem. It's a polyendocrine metabolic dysregulation, and the ovaries took a hit. And we're grateful
Mhm.
that this broader definition provides a broader lens for us to look at the patient more carefully to prevent long term side effects that may include premature death when not managed aggressively. So, thank you, Nancy, for teaching me this connection. And thank you to the Endocrine Society for changing the name to open the eyes of the medical world and patients alike to pay attention to this condition.
I'm Dr. Kathleen Carson, and thank you for joining us and helping to realize that the mouth is not separate from the body. It's part of the airway, the immune system, the nervous system, and the inflammatory system. Everything's connected.
And I'm Dr. Ellie Campbell. Thank you for watching Sleep, Sex, and Senility. We look forward to having you on our next episode and are grateful that you joined us today. Thank you so much for joining us for this episode of Sleep, Sex, and Senility. If you enjoyed today's conversation, please like, subscribe, and share the podcast with a friend.
Visit our website at sleepsexandsenility.com to sign up for our monthly newsletter using the link on our homepage. New episodes drop every Tuesday.
Until next time, keep connecting the dots and remember, what happens in your mouth doesn't stay there. I'm Dr. Ellie Campbell.
And I'm Dr. Kathleen Carson.
Nanoverse Media, making the world smaller.